Welcome back to Neurology 101 here on the ProPA podcast. I'm Dr. G, and today we're continuing our vascular neurology series with an important warning shot of a diagnosis: TIAs, or Transient Ischemic Attacks. It may leave no permanent mark, but it should never be ignored. Let's dive in. Did you know about 1 in 3 patients who experience a TIA will go on to have a full-blown stroke? Half of them within the first 48 hours? That's why a TIA is sometimes called a mini stroke, but the better term is a major opportunity. Let's look a little deeper at the kinder Patho. What is a TIA? Well, a transient ischemic attack is a brief neurological dysfunction caused by focal cerebral ischemia without acute infarction. That means a temporary blockage of blood flow to the part of the brain, spinal cord, or retina, usually lasting less than an hour, and completely resolving. Unlike a stroke, there is no evidence of infarction on imaging. However, the risk of a future stroke, especially in the first 48 hours, is high. Common mechanisms include embolism from carotid or cardiac sources, small vessel disease, and less often, hypercoagulable states. So, how does the classic TIA present? Well, unilateral weakness or numbness, speech difficulty like aphasia, the amaurosis fuga, which is a transient monocular blindness like a curtain coming down, and symptoms typically resolve within minutes to an hour. An important note is if symptoms last greater than an hour or imaging shows an infarct, it's a stroke, not a TIA. What about the diagnosis? Well, we want to get a CT head without contrast, and this is the first step to rule out a hemorrhage or stroke. Then we want to consider an MRI with DWI, which is the preferred to rule out infarct. We can also consider vascular imaging like carotid duplex, a CTA, or MRI head and neck. Cardiac workup includes EKG, looking for AFib, and an echocardiogram. Lab work includes CBC, lipids, glucose, and A1C, and coag studies. You can use the ABCD2 score to estimate 2-day stroke risk. These stand for different things. The A stands for age, greater than or equal to 60. B stands for BP, greater than or equal to 140/90. C stands for clinical features like unilateral weakness, you get 2 points, or speech only 1 point. Duration, greater than or equal to 60 minutes, gets 2 points. Anything from 10 to 59 minutes gets 1 point. And diabetes, which gets 1 point. A score greater than or equal to 4 has a higher risk, and you want to consider hospitalization. All right, now let's look at the treatment. So, antiplatelet therapy like aspirin or a dual antiplatelet like aspirin plus clopidogrel is the short-term treatment. We also want to consider statin therapy, which is high-intensity statin regardless of cholesterol. We want to manage underlying causes. So, if it's from carotid stenosis, which is greater than 70%, they may need an inotorectomy. If it's from atrial fibrillation, we might consider anticoagulation like a DOAC or warfarin. Patient education is critical. Lifestyle, smoking cessation, control of hypertension, diabetes, and the lipids is very, very important. All right, book med versus street med. So the book med, TIA is defined as a neurologic symptoms lasting less than 24 hours, but newer guidelines emphasize tissue-based diagnosis, symptoms without infarct on MRI. Street med, your patient says, I couldn't move my arm or talk, but it got better by the time EMS arrived. You're not off the hook. This is your chance to prevent the next life-altering event. All right, some quick clinical pearls. So a TIA is a warning stroke. Take it seriously. Resolution of symptoms doesn't mean resolution of risk. An MRI is better than CT at detecting ischemic lesions. We want to consider the high-risk ABCD2 and admit for workup. And early intervention equals better outcomes. All right, it's time to test our knowledge with some practice PANCE questions. Question 1. A 66-year-old man has sudden right arm weakness and speech difficulty that resolves in 30 minutes. His CT is normal. What's the most appropriate next step? Is it A, discharge home with aspirin? B, schedule an outpatient MRI in 2 weeks? C, admit for MRI, vascular studies, and cardiac eval? or D, start TPA? I'll give you a few seconds. If you said C, admit for MRI, vascular studies, and cardiac eval, you are correct. Remember, a high-risk TIA, you need to admit these patients and investigate their source to prevent the stroke. Question 2. Which finding most strongly suggests a TIA rather than a stroke? A, a facial droop and hemiparesis. B, a normal brain MRI with symptom resolution in 30 minutes. C, a positive Babinski sign. Or D, slurred speech lasting greater than 24 hours. I'll give you a few seconds. If you said B, normal brain MRI with symptom resolution in 30 minutes, you are correct. A TIA is defined by transient symptoms without infarction on imaging. Alright, so some final thoughts. The patient may feel fine, but if you miss a TIA, the next event may not be so kind. Catch it, work it up, and intervene early. Next up in the vascular neurology series, we have ischemic stroke, and we'll break it down via thrombotic versus embolic types and what to do when seconds count. If this episode helped you recognize the urgency behind mini strokes, send it to your study group or a future preceptor. And remember, this is the Pro PA podcast, where future pros in medicine are made. Catch you in the next one.